Hello, and welcome to the Clinical Care Options Oncology Podcast. I'm your host, Tim Quill. Today's episode features Dr. David Miller from the University of Texas Southwestern Medical Center in Dallas, Texas, and Dr. Linda Duska from the University of Virginia School of Medicine in Charlottesville, Virginia. They will be discussing practice-changing data and other new findings for endometrial, cervical, and ovarian cancers presented at the 2023 SGO annual meeting held in Tampa, Florida. This episode is part of a larger educational program entitled Key Findings and Expert Recommendations in Gynecologic Malignancies, Independent 2023 Conference Congress coverage. For more information on Dr. Miller and Dr. Duska, along with a link to the complete program, including a downloadable slide set and clinical commentaries, please visit the show notes for this episode. Now let's get started and hear what the experts have to say about key new data presented at the 2023 SGO annual meeting.
Welcome. I am David Miller. I am the immediate past chief of gynecologic oncology and professor of obstetrics and gynecology here at the University of Texas Southwestern Medical Center in Dallas. It is my great honor today to be joined by my esteemed colleague, Dr. Linda Duska, who is a gynecologic oncologist and professor of obstetrics and gynecology at the University of Virginia School of Medicine in Charlottesville. Welcome, Dr. Duska.
Thank you, Dr. Miller. It is such a pleasure to be here with you today.
And today we have the great privilege of going over some of the highlights of our most recent Society of Gynecologic Oncology meeting that was held in Tampa, Florida in late March. And we have 5 studies that we've selected that hopefully you will find interesting and entertaining. And I will kick it off by talking about 2 of the real headline events for the SGO meeting. I've been going to this meeting for about 40 years, and I think this is the first time where we've seen 2 late-breaking, practice-changing abstracts, which were also simultaneously published in the New England Journal of Medicine. And so I think that was quite a coup for the society, and I think you will see that it also is a coup for our patients. And so the first study in the order they were presented first by Dr. Ramez Eskander from UC San Diego was the results of the GY018 trial, which was carboplatin and paclitaxel with or without pembrolizumab as frontline treatment in advanced recurrent endometrial cancer. And this study involved a population similar to several other advanced endometrial trials, measurable disease patients, advanced stage 4 patients, and it was basically chemotherapy with carboplatin and paclitaxel at the usual doses with or without pembrolizumab for 6 cycles. And then it was followed by an additional 14 cycles of pembrolizumab at 400 milligrams every 6 weeks. The primary endpoint was progression-free survival as assessed by RECIST, and the study was done in 2 cohorts of proficient mismatch repair and deficient mismatch repair patients. When you looked at the patient populations, they were pretty well balanced between the placebo and the control arm. Notable for about 30% of patients that were non-white. There were about 25-30% of patients had the so-called high-risk histologies, either serous or clear cell, and as you would expect, virtually all of those patients were in the mismatch repair proficient cohort of patients. And so what they found, looking at progression-free survival, was a significant advantage for the addition of pembrolizumab to carboplatin and Taxol chemotherapy. When they looked in the mismatch repair deficient cohort of patients, the median progression-free survival has not been reached. In the treatment arm and was 7.6 months in the placebo arm with a hazard ratio of 0.3. When they looked at in the mismatch repair proficient arm, the median progression-free survival in the pembrolizumab arm was 13 months compared to 9 months in the placebo arm with a hazard ratio of 0.54. When they did the forest plots, looking at various subgroup analysis, we saw a pretty much uniform advantage across the various subgroups for the addition of pembrolizumab, as well as in the more high-risk histologies, clear cell and serous patients. This was a relatively toxic treatment, but otherwise pretty well tolerated, with toxicities, particularly grade 3 toxicities, were more often seen in the treatment arm with pembrolizumab, but that most patients were able to tolerate that therapy. The most common toxicities in both the cohorts were fatigue, peripheral neuropathy, anemia, nausea, and constipation. When we look at the toxicities most typically attributed to immune therapy, again, as we would expect, they were more common in the pembrolizumab arm with hyperthyroidism at around 12 to 13%, hyperthyroidism at 5 to 9% in the treatment arm. The other trial that was presented at that late-breaking session after Dr. Iskanders was by Mansour Mirza, and that was the presentation of the RUBY or GOG 3031 trial, which was with the addition of dostarlimab to carboplatin and paclitaxel chemotherapy, again, an advanced recurrent endometrial cancer. In this case, the chemotherapy and dostarlimab or placebo were given for 6 cycles. And this was then followed by dostarlimab at 1,000 milligrams every 6 weeks for up to 3 years as maintenance therapy. The primary endpoint was progression-free survival by investigator assessment. Again, here the populations were relatively well matched. One of the main differences between the RUBY trial and the GY018 trial was the inclusion of carcinosarcoma patients, which even then only accounted for about 10% of patients, but serous and clear cell patients were also included. And so what they found when looking at their primary endpoint of progression-free survival at 2 years, that was in the overall population, that was 36 months in the dostarlimab arm compared to 18 months in the placebo arm with a hazard ratio of 0.64. When we break that down to our 2 main subgroups of interest, whether the patients were mismatch repair deficient or proficient, in the mismatch repair deficient group of patients, the addition of dostarlimab led to a 2-year progression-free survival rate of 61%, compared to 16 months in the placebo group of patients with a hazard ratio of 0.28. In the mismatch repair proficient patients, we did again see a separation of the curves with a much less magnitude, but still a significant separation with a progression-free survival of 28 months in the dostarlimab arm versus 19 months in the placebo arm with a hazard ratio of 0.76. When you looked at overall survival data for the dostarlimab arm, the median overall survival was 71 months in the dostarlimab arm versus 56 months in the placebo arm with a hazard ratio of 0.64. Again, when we break that down into mismatch repair deficient and proficient, in the mismatch repair deficient patients, the addition of dostarlimab yield a 2-year survival of 83% compared to 59% in the placebo arm with a hazard ratio of 0.3. There was still separation in the survival curves when we looked at the proficient mismatch repair patients. with 68 months in the dostarlimab compared to 55 months in the placebo arm, with a hazard ratio of 0.73, which was not quite significant as the hazard ratio included 1. They also looked at response rates, which were very similar between the two arms, around 60 to 70%. But what was notable was the duration of response. And in the dostarlimab arm, in the mismatch repair deficient patients, the median duration of response has still not yet been reached, whereas in the placebo arm, that duration of response was 5 months. When we looked at the proficient mismatch repair groups, the dostarlimab arm had a median duration of response of about 9 months compared to 6 months in the placebo arm. Again, the treatments were toxic but tolerated, with grade 3 toxicities more commonly seen in the dostarlimab arm at 71% compared to 60% in the control arm, and the immune checkpoint inhibitor only had to be discontinued in about 17% of the patients. When you compared the various toxicities, the main significant difference in toxicity, interestingly, was an increase in grade 3 rash in the dostarlimab arm. They did also look at quality of life and found a significant advantage to quality of life, particularly during the maintenance therapy part of the treatment. Presumably, this may be related to disease progression in the placebo arm. So that is where the two late-breaking big abstracts in endometrial cancer, and we can anticipate that we should be seeing a significant practice change in our approach to advanced endometrial cancer.
Dr. Miller, thank you for that really nice summary of these two studies. And I'm going to say this raises two questions for me. So I have two questions for you, and I'll start with your comment about practice changing. And the question I have for you, well, it's actually there's part A and part B. So the first is, when do you think we should be changing our practice? Should we be changing it now? Or should we be waiting for formal approval? And the second question is, should we be changing our practice for both MMRD and MMRP patients now?
Well, I think the big question is, we've already addressed or trying to address this in my own group. You have patients who are on carboplatin and Taxol for advanced endometrial cancer, and do you add pembro? And I can tell you, for us, our main impetus to do that is if we say have a patient who's maybe not quite responding or has stable disease. We've been adding pembro in that group of patients. But I think, at least depending on what insurance will pay for, and I'm sure very shortly, since we have publications, that this will be reimbursed when you have that luxury of taking care of an insured patient. Now, that does leave us with a couple unanswered questions, like what are we going to do in that smaller group of patients that progress? Do we have an answer yet, which I don't think we do, of immune checkpoint therapy after immune checkpoint therapy?
Well, you anticipated my second question, and that's what it was. So I feel, right now, to your point, our second-line therapy for relapsed patients is immune checkpoint inhibitor for those that are MMRD, and immune checkpoint inhibitor plus lenvatinib for those that are MMRP. And I'm just wondering, if we're moving checkpoint inhibition into the front line, what we're going to do in the second line. I don't think we have data for checkpoint inhibitor after checkpoint inhibitor.
I agree. And one thing we've kicked around here is that maybe we should use dostarlimab in our first-line therapy, and then if the patient does progress, and we want to return to an immune checkpoint inhibitor, we then can use a different one, pembrolizumab, with or without lenvatinib, depending on the mismatch repair status. So that's one strategy that we've kicked around.
Yeah, but there's no data that they...
Oh, of course not, yes.
So actually, that brings up another point. So how would you choose? So if you're putting a patient, let's say MMRD, on paclitaxel, carboplatin, and a checkpoint inhibitor, how would you choose pembrolizumab versus dostarlimab?
Well, for us, we're trying to get dostarlimab on formulary here because when dostarlimab came out, it was priced higher than pembrolizumab, so I didn't get much traction with the pharmacy trying to get it. Now that it has some more approvals, I think we'll be able to make some progress with that. But I think, once it becomes available, again, I'd kind of be a little biased to starting with dostarlimab, just so thinking in anticipation of what might be happening with second-line therapy, because we don't have a pembrolizumab equivalent with dostarlimab that I'm aware of. So that's just sort of speculation.
Fair to say in the upfront setting, we don't have a sense that one is any different or better than the other. Fair?
Exactly.
Yeah. Okay. Well, thank you so much. That was such a helpful distillation of the abstracts. I agree, they're practice changing and very, very good for our patients. And I completely agree with what you've said. I'd like to move on to talk about cervical cancer, and then one quick abstract in ovarian cancer if we have time. Similar to the situation with endometrial cancer, there's a lot of interest in moving immunotherapy into the front line for locally advanced cervical cancer, and there continues to be an unmet need in the area of locally advanced cervical cancer. We're doing better with the addition of cisplatin to chemo-RT, but we're just not quite there. Although honestly, I think prevention of cervical cancer is where we really need to be focusing. There were two abstracts presented at the meeting in Tampa that examined the question of sequencing of immunotherapy with chemoradiation in the upfront setting for locally advanced cervical cancer. We know that the combination of the PD-L1 inhibitor durvalumab concurrent with chemoradiation, followed by durvalumab maintenance, this was the CALA trial, failed to meet the pre-specified PFS endpoint. It's not really clear to me entirely why that happened in that particular trial, and there are a lot of theories about that, which I don't have time to go into now. But there was actually even a theory that maybe adding the immunotherapy to the chemoradiation therapy might adversely affect overall outcome. And this question of sequencing, particularly with radiation, is a really important question to answer. And I think, in my mind, the best way to answer that is at the translational or biologic endpoint. And so, there's another study ongoing with pembrolizumab called the GOG-3047 trial. That study has completed accrual, and we're waiting for the results of that trial. But we heard about some translational data regarding sequencing from the two SGO abstracts that I'm going to talk about now. So the first one was the NRG GY017 trial. And both of these studies were asking the same sequencing question with a little bit of variation. Both of them had safety and immunologic endpoints as primary endpoints, and neither study was powered for PFS or OS, although, of course, both of them showed results from this. And both asked the same question: how does differential sequencing of radiation and immunotherapy blockade in cervical cancer impact the immune response and therapeutic efficacy? So in this trial, patients with locally advanced cervical cancer were put on one of two arms. In arm A, they received atezolizumab, one dose as a priming dose before chemoradiation therapy, and then two doses during chemoradiation therapy. And then in arm B, they received the same 3 doses, but during chemoradiation. So the main difference was in arm A, there was this so-called priming dose. In this study, there were tumor biopsies collected and blood samples collected so that they could answer the question. They wanted to identify biologic parameters that could predict immune response. That was the main goal of this study, as well as to identify safety. So there were a total of 36 patients who were entered on this study. The PFS was 79% at 26 months in the priming arm and 59% in the concurrent arm. So the study was not powered to show a difference in PFS, so there's really nothing that we can say about this, except that giving the priming dose did not adversely affect outcome. That's really all we can say. And it's really difficult to make any conclusions based on this data because, again, this study was not powered to look at a difference in PFS between the two arms. However, what's really interesting about these data is that the priming dose appeared to lead to an early systemic expansion of tumor-associated T cell clones, which is really interesting and suggests an early systemic tumor-specific immune response. This was not seen in Arm B. So remember, everybody got 3 doses of atezolizumab, but in Arm A, they got a so-called priming dose. And this seemed to result in an early systemic expansion of tumor-associated T cell clones, while in the non-priming arm, there was a tumor-associated T cell clone contraction. So that's hypothesis generating, really, but it can help us in study design moving forward as we continue to look at this idea of moving immunotherapy into the frontline for locally advanced cervical cancer. The second study, and in the spirit of full disclosure, I'm going to tell you the second study was mine. This was a randomized phase 2 trial, essentially the same population of patients, but in this case, the drug was different. It was pembrolizumab, and we were asking a different sequencing question. Patients received 3 cycles of pembrolizumab, similar to the prior study I talked to you about. We didn't have a priming of the IO. Patients either got the pembrolizumab during chemo-RT or after chemo-RT. And the question we wanted to know was, first of all, is it safe to give IO during chemo-RT in this patient population? But secondly, would we see a different immune response? And our primary endpoint was an immunologic endpoint, and we defined it as the change as a function of intervention on the ratio of CD8 T cells divided by T regulatory cells. We also, similar to the GY017, had multiple tissue biopsies, multiple blood biopsies. We also included, as did the authors of GY017, some data on PD-L1 staining, and we looked at PET scan response. So similar to GY017, we were able to show that this regimen is safe and tolerable. And actually, that safety and tolerability data have already been published, similar to GY017. Unfortunately, our primary endpoint was negative. We were not able to see a difference in CD8 T cells to T regulatory cell ratio, either in tissue or in blood, between the two arms. This, in part, was probably due to the fact that there was significant patient variability. However, we did see different patterns of change in E7 peptide in peripheral blood. We saw increases in all of E7 and 1 E6 response only if pembrolizumab was given during chemoradiation. So that was really interesting. We also saw both sequences altered multiple immune cell populations, and we're doing further work in that area. So more to come on that. Also, similar to GY017, showed endpoints regarding response rate and survival. And again, this study was not designed to compare treatment responses between arms, but we were able to show that the complete response and partial response rates for the two arms were virtually identical, and the PFS and OS favored the concurrent arm. So for those folks that were concerned from the CALA results that maybe giving durvalumab during CRT was actually negatively impacting patients, at least in this study of 96 patients, we were able to show that there wasn't a concern of combining pembrolizumab with chemoradiation therapy. And then our PD-L1 data were really interesting. We saw a significant increase in PD-L1 expression only in those patients that received pembrolizumab after chemoradiation therapy. So again, a lot of hypothesis generating information from these two studies that I'm really hopeful will be able to help inform future studies. We need to wait for the results of GOG 3047, which will be really interesting, I'm sure. And the results of these studies plus GOG 3047 will be very informative, I think, in planning future studies. The last study that I just want to mention was a study presented by Dr. Brian Slomovitz, GOG 3026. This was a phase 2 trial of letrozole and ribociclib in women with recurrent low-grade serous ovarian cancer. This is a rare disease which is in dire need of new therapies. This was designed as a single-arm, open-label phase 2 trial for advanced and recurrent low-grade serous ovarian cancer. And we do know that for women who have had multiple prior lines, there are low response rates to aromatase inhibitors, chemotherapy, and even MEK inhibitors, so there is truly an unmet need. There's also a scientific rationale for this combination and a theory that ribociclib, a CDK4/6 inhibitor, combined with letrozole may reverse hormonal resistance. So in this trial, patients with low-grade serous ovarian cancer were entered and were allowed to have unlimited prior lines of therapy, although no prior letrozole was allowed, and the primary endpoint was overall response rate. 51 patients were enrolled and 48 were evaluable. The majority of them, 73%, had prior chemotherapy. The overall response rate in this study was 23%. All responses were partial responses, but of note, the duration of response was 19 months, with a median PFS of 19 months and a median overall survival that was not reached. This was a very well-tolerated regimen. The most common high-grade toxicities were hematologic, and patients did very well on this combination. And so when Dr. Slomovitz showed us the table of alternative therapies for patients in this category, this study had the longest progression-free survival and the longest duration of response, suggesting that this is a viable alternative for these women. And the translational endpoints for this study are pending, but should be really interesting because maybe they will help us target this combination of therapy appropriately to women who've had multiple prior lines of therapy.
Well, thank you for those very interesting and excellent summaries. It is very encouraging to finally see something with actual activity in low-grade serous ovarian cancer, and we look forward to hopefully some more advances, particularly in utilizing targeted therapies. Your summaries on the immune therapy for cervix cancer were very interesting. I do recall that maybe a decade or two ago, we used to talk a lot about using neoadjuvant chemotherapy in locally advanced cervix cancer, and that eventually didn't pan out. You a little more optimistic about the addition of immune therapy?
That's a really good question. I think we need to have a better understanding of the biology. So we know that immunotherapy is not, as a single agent at least, is not super great for recurrent cervix cancer, right? So the question is how to make the environment, so to speak, more conducive to immunotherapy success, and whether that's giving the immunotherapy during radiation, giving it after radiation, because there's a concern that maybe the radiation is killing off all the T cells that you're trying to stimulate with the immunotherapy, or whether the best idea is to give the immunotherapy up front. I think we just don't understand the biology as well as we need to in order to rationally design these trials. And that's why the two trials that were presented at SGO are so important, because we need to do this kind of work in order to best understand sequencing. So am I hopeful? Yes, I think understanding the biology will help us more rationally design these studies. But honestly, I think prevention for this particular type of cancer is key, as I said earlier. And what we ultimately really need to do is eradicate cervix cancer by preventing it altogether.
Clearly, that's the most important thing. You mentioned the CALA trial, and I had always sort of assumed that maybe durvalumab was the problem in the CALA trial.
Hard to say. I think there are a lot of theories about why the CALA trial was negative. Maybe they didn't choose high-risk enough patients. 3047 is looking at a slightly different population of patients, so maybe that was the problem. Maybe they weren't targeting the right patient population. Maybe it is the wrong checkpoint inhibitor. I don't know the answer to that question. I think the results of 3047 will be very informative there, right? Because if that's a positive trial, then there will be a lot of theorizing about whether it was actually the checkpoint inhibitor chosen or whether it was the population of patients that was looked at. And we'll have to do a whole lot of subset analyses to answer that question. I think we need more data, and fortunately for all of us, more data are coming regarding the answer to your question.
And you want to remind the audience what the GOG 3047 is, what they can look forward to?
Sure. So 3047 is a very similar trial to the CALA trial. Patients with locally advanced cervical cancer receive standard of care chemoradiation therapy with or without pembrolizumab. And the pembrolizumab is given during the chemoradiation therapy and then in maintenance. So very similar to the CALA trial, with the exception of the difference in the checkpoint inhibitor and then some other differences with respect to eligibility criteria. That study completed accrual, and so we're anxiously awaiting the results.
Yes, we look forward to those results. I want to thank Dr. Duska for her great discussion and analysis. I hope our audience found this educational, if not entertaining. And I'd also like to thank our friends at Clinical Options for sponsoring this. And I would encourage you to go to their websites. They produce some most excellent slides that they are very generous in sharing with providers, and I call on them frequently. So I hope you have a very good day. Thank you.
Thank you.
Thank you very much, Dr. Miller and Dr. Duska, and thanks to you, the listeners, for joining us. As a reminder, to view the full program, key findings and expert recommendations in gynecologic malignancies, independent 2023 Conference Congress coverage, and to download a highlights slide set including the various studies associated with this discussion, please click on the link in the show notes. As always, thanks for listening.